So we're going to do flexion and extension of the cervical spine, range of motion. So we're going to start with some active range of motion and start with flexion. I'm going to measure that. So Jack, I want you to make sure you're sitting up straight, okay? And then I want you to keep your mouth closed and then just try to touch your chin to your chest. As far as you can go. Okay, so for our points, we're gonna go with the axis here at the external auditory medius, and then your stationary arm is going straight up and down vertically, and then you're following the nose. And bam. And then you can go ahead and do some passive by adding overpressure here, and then measuring that as well. Get a couple more degrees out of that. Okay, and then you have relax. Okay, so for that, we get around, I think we gained about 2 or 3 degrees there, so about 46 degrees with the passive. So the average is about 50, so he's a little lacking in that, but that's okay. And then we're gonna go next for extension. So for this one, we also want him to set straight up, and then we're gonna start with our active motion. Same thing, external auditory medius, and then we're going to the nose. So Jack, can you just look up to the ceiling, keeping your back straight as far as you can? Great job. Okay, so he's just shy of 60 there, so about 57. And then you can go on the forehead right here and just add a little bit of overpressure to get just about an extra degree, so 58. So he's pretty close to normal, and normal would be 60 degrees for that. And that is flexion extension. So now we're going to do cervical range of motion. So for this, Jack, I want you to set straight up as you can, and I'm going to line up. We're going off the top of the head, and then we're going to the acromion, and then straight through the nose. So I can't really get a good view right here, but I'm going to try. So Jack, can you go ahead and try to look over your shoulder that way to the right as far as you can? Great job, great job. And okay, so I can apply a little bit of overpressure right here at the chin. And then look at that. So that gave me a couple more degrees. Hard to control. Yep. Good. So for that, you're at about 62 degrees with the added overpressure. Something to note with the passive range of motion there, you don't want to apply passive range of motion if your patient's already experiencing pain or reproduction of symptoms. You just apply that like afterwards. So as far as range of motion for rotation, 80 degrees is normal, so Jack's at around 62, 63, so he's just below normal there. Okay, so now we're going to do lateral flexion. So it's a very similar setup to the ones we've done so far. So we're going to have Jack go ahead and set up as straight as he possibly can. Great job. And then we're going to go ahead and find C7, so it's right there. That's where we're going to put the axis. So your stationary arm is just going to go straight up and down vertical to the ceiling. And then your moving arm is going to go with his occipital protuberance. Jack has a very protubed protuberance. But yeah, so Jack's sitting straight up, and just keep that, you want to cue your patient to keep on looking straight ahead, and to go ahead and try to touch his ear to his shoulder is a good cue for this. And then there's his protuberance, and then he gets around 26, 27 degrees. You can go ahead and add that over pressure just like that, and he gets a few extra degrees out of that. Okay. And then you only want to add the overpressure if he has pain. He gets around 29, almost to 30 with that. So normal would be about 45, so he's a little bit below normal, but that is lateral flexion range of motion. Okay, so now we're going to go ahead and do manual muscle tests for all the cervical ranges of motion. So to start out, we're going to start out with cervical flexion. So can you go ahead and just flex forward just a little bit, bring your head forward. Okay, so you kind of push on the forehead right here is what I like to do, and just grade your force slowly and don't really break them. You don't really need to. It's not necessary. Just try to grade that from a 0 to a 5. 5 just being pretty strong, really strong. So then we're going to go ahead and do extension. So kind of look up a little bit for me right there. That's good. And so I'm going to press on his chest. Now with a lady, you want to go ahead and ask them that before. Just press a little bit above right there, and then grade your force again. And then you got that. Okay, so now we're going to go ahead and do lateral flexion. So I'm going to have you bring your head just a little bit towards this side of your shoulder. Down, good. And so I like to grab right here and push. Great job. Also, you want to ask if they have any pain or reproductive symptoms with this, as it may. No?
No, I'm good.
Oh, no.
No, it's
Okay.
I don't have any pain. Yeah.
Okay.
No, you're doing fine.
So now we're going to go ahead and do cervical range of motion. So same deal, Jack. I'm going to have you go ahead and look a little bit that way. That's good. So I'm going to go ahead and bring my forearm through like this, and my hand over here, and then push. Good. So yeah, you want to cue your patient to hold that. Obviously, Jack knows what he's doing, so you need to do that. But and that is manual muscle test for the cervical range of motion. Okay. So I'm gonna go over the what a dermatome is and what a myotome is before I even start like describing the dermatomes and myotomes. So a dermatome is an area of skin that is supplied by a specific nerve root. And by supplied, I mean sensation like pain, temperature, touch. And that just lets us know, by assessing those, that'll let us know if there's a specific nerve root involved, like maybe a compression of that nerve root or something of that nature. Same thing for dermatome, except with this one, we're really looking at muscle and muscle action. So we found out that with myotomes, some specific nerve roots supply specific actions of muscles. And I'll go over those right now. So for the upper extremity, we'll start with the dermatome. So for the C5 dermatome, we're going to go right here, the lateral part of the shoulder. And then for C6, I'm going to flip his hand over. It's going to be the palmar aspect of the thumb. And then C7 is going to be the palmar aspect of the middle finger. C8 is the palmar aspect of the pinky finger. T1 is going to be the medial side of the arm right here around the elbow area, just above. And then T2 goes right here in the armpit. You kind of say T2PU is the way I remember that. So then going through the lower extremity dermatomes, we have the L2 is going to be around the iliac crest area.
Here, I'll slide down for you. See the whole leg.
All right, L2 is going to be the iliac crest area. Then L3 is going to be just above the knee. It's kind of the medial side of the knee, kind of follows the sartorius. And then we're going to go down here to L4, which is going to be the medial malleolus. L5 is going to be the dorsum, or the top of the foot. And then S1 is going to be the lateral malleolus. Okay, so for these, for the myotomes of the lower extremity, we're going to have L2 is going to be hip flexion, so bringing your leg up. So you could do a manual muscle test here, but you don't necessarily have to. If they can't get their leg up against gravity, that would also be positive, of course. And then for L3, it's going to be knee extension, straight out. And then for L4, it's going to be dorsiflexion. L5 is going to be great toe extension, which I have trouble doing, but Jack does great. And then finally for S1, just plantar flexion, which yes, you can do it just like that.
Or either one.
And those are the dermatomal and myotomal areas of the leg. So actually through research is how we figured out that there are specific areas and specific muscles that are better than other, because there are variants of these areas. So we like to pinpoint specific areas, and that's why I indicated those areas. Okay, and then now we're going to go ahead and do myotomes for the upper body. So first of all, you've got C5, which is going to be shoulder abduction, abduction. You can do a manual muscle test here, of course. Okay, and then we're going to go ahead and do C6, which is going to be elbow flexion or wrist extension. And then C7 is going to be elbow extension and then wrist flexion. Okay, and then C8 is going to go ahead and be finger flexion, and then C9 or T1, the proper term, is going to be that finger abduction. Okay. Next step, we're going to take blood pressure, and as you can tell, I've already got the cuff on Jack. So as far as putting the cuff on, what you want to do is you want to find a cubital fossa right here on their anterior arm. So this contains the brachial artery, which is the artery we're actually including with the blood pressure cuff. On the cuff, you have these two little arrows. One will say right arm, one will say left arm. I'm doing Jack's right arm right now. So you want to position that over the cubital fossa, pointing down towards it. And then before you actually take blood pressure, you want to make sure that the patient is sitting up straight, feet flat on the floor uncrossed. And then ideally you want their arm to be raised above their heart, and that's why I have this chair here. And then we go ahead and put our stethoscope in. You want to make sure that the earpieces are pointing forward like that. That way they actually go into your ear. And then for the grip on the stethoscope, you want to go ahead and grip it with two fingers like that. That way you're not over the top, because that can kind of mess with your sound that you hear. So you go ahead and tighten your bulb up. Place this over that cubital fossa. And Jack's already told me that his blood pressure runs about 120/80, so that's pretty normal, which is normal. So you want to go about 200 millimeters of mercury above that, which would be about 140. So I'm going to go ahead and pump him up here to about 140 there, and then I'm going to slowly let it out. Okay, so Jack is actually about 115/58, which is pretty good. Like I said, normal runs between about 120/80. So for letting the air out of this thing, you want to make sure you're at about 2 millimeters of mercury per second when you're letting it out. And that's how you take blood pressure. Okay, today we're going to be doing the upper limb tension test with an ulnar nerve bias. So my table is really low, so I'm going to do the best I can, but in a normal setting with a high-load table, you want to adjust it for body mechanics and things like that with everything that you do as far as treatment goes. So we start with depression. I like to push my hand down into the table, and then you're going to say, does that reproduce your symptoms?
No.
Okay. Then we're going to go to abduction, and then you're going to say, Jack, does that reproduce your symptoms? And if your patient's not Jack, don't say Jack. So then we're going to go into pronation and external rotation, and then you're going to say, do you feel any symptoms, Jack? Okay, hot dog. So I like to put my knee right here against the elbow to give me a firm hold on that, and then you take them into wrist extension. Make sure you get all those fingers, and then you ask your patient if they feel any symptoms.
Nope.
Okay. And then we're going to go ahead and go into flexion as not the final step, and we're going to ask him if he feels any symptoms here. Woo! Okay. So the final step is getting all the way here, and then telling the patient to turn their head, and then again asking if they feel any symptoms. So it's really important at each step to ask them that. I know you sound repetitive, but some patients, might not tell you if they feel those symptoms. So that's an important component. As I said, it's the ulnar nerve tension test, so we're testing for some sort of ulnar nerve pathology, whether that be TOS or anything like that. So, and that is the upper limb tension test with an ulnar nerve bias. All right, so today I'm going to do cervical traction. So there are two hand placements of cervical traction, one of which doesn't really agree with the sweaty nature of my hands, so I'm going to do the second, which is like the chin grip cradle. So you do cervical traction when you're going through your cervical exam, you find that they have centralizing or peripheralizing symptoms with those movements. So in that case, you only need, according to the book, around 5 to 10 pounds of pressure with traction. And I like to slide my forearm in here. And then my thenar eminence goes just under the base of the occiput. And so then I'm going to apply pressure. So you can grade this pressure according to how the patient feels. If they complain, and you want to ask about symptoms as well. So you want to come just shy of those symptoms when you're working in that range. Usually you want to hold it for about a minute. You can hold it a little longer, like I said, depending on the patient's reaction to the cervical traction. And that is cervical traction. Okay, so I'm going to be doing the Sperling's test for cervical radiculopathy. So to begin this test, you go ahead and have your patient just set straight up down posture, head in a neutral position, cervical spine in a neutral position. Then from this point, you want to go ahead and assess if your patient's having radicular symptoms or concordant signs that are present when their symptoms are present. So Jack, do you have any signs or symptoms?
Nope.
Okay. Then from that point, you can go ahead and have your patient just slightly bring your ear to your shoulder. Right there, that's good.
Okay.
Any signs or symptoms with that?
Mm-mm.
Nothing? Okay. And then from this point, after you check that, you can come in here and you go ahead and give a little axial pressure
Ooh.
through the cervical spine and then ask if there's any signs or symptoms.
Oh yeah.
Oh yeah.
Oh yeah.
So as I said, that flexion, that lateral flexion is going to be to the same side that they're having their signs or symptoms. And a yes for signs and symptoms could indicate some sort of cervical radiculopathy, and that is the Sperling's test. Okay, today we're going to be performing the hyperabduction test. So to start this test, you want to go ahead and find the radial pulse, which is just right here on the lateral side of the forearm, just proximal to the thumb. And I can feel Jack's. Okay, so next step is you want them to raise their arm up in the abduction, and then make like a goal post at 90 degrees, and then fully externally rotate. Have them hold that for 1 minute, and then at the conclusion of 1 minute, you can go ahead and relax. Then you go ahead and reassess. So all the while, you're going to be asking your patient if they have any reproduction of symptoms, specifically paresthesia will be a positive sign, or diminished pulse will be a positive sign for this test. Now, a positive sign would indicate possible thoracic outlet syndrome. So that is the hyperabduction test. Okay, today we're going to be doing the modified sharp pursers test. So the modified sharp pursers test is a test for ligamentous instability, specifically at the atlantal axial joint. So this test can be used, like I said, to screen for that, or in order to screen for to do a cervical manipulation or high velocity manipulation at the cervical spine. So you want to start out by locating the C2 spinous process. So you're going to start at the occipital protuberance, and you're going to go down. The first protuberance that you feel is going to be the C2. You want to get a pincher grip around that C2, which is just gripping it like this, in order to stabilize C2. Okay, so I've got C2. And then next you're going to have your patient just slightly nod their head down towards the floor a little bit. That's good. This may reproduce their symptoms, in which that would be a positive sign. So then what we want to do is we want to provide a force through the forehead going this way as I'm stabilizing with this hand. So we provide that force, and then we're checking, like I said, for any sort of instability, reproduction of symptoms, and with that you may get a decrease in symptoms, which would also be a positive, and that is the modified sharp pursers test. So today we're going to be doing the cervicothoracic manipulation. So this before you even start to perform this manipulation, you'll make sure you screen for VBI or any sort of cervical instability. So after that, you go ahead and get your patient set up. You want to have them laying prone on the plinth or bed in our case. And anyways, you go ahead and have them scoot towards me. scoot towards me, and let this shoulder lay off to the side. Yep, this shoulder right down on your side, and then you're going to have them look towards you. Okay, so after they're in that position, you go ahead and you find your T1. So there'll be two really prominent spinous processes right here, just above the spine of the scap. So that's where that T1 is. So you want to find that, and then you get your thenar eminence right up against there, and then you go ahead and apply some force, and then you walk them out. So they should be looking down towards the floor. This is kind of a tough position because, can you scoot just a little bit towards me?
Sorry.
That's okay. Okay. So you go ahead and walk them out here, and then what we want to do is we want to side bend away. We walk them out there. So this should be about 60% pressure. Your angle of force is going back towards me this way. And then you're going to give about 40% pressure here. You give that high velocity manipulation right there, which we're not going to do today. And then that is the cervicothoracic manipulation. Manual therapy. This manual therapy technique can be used for a decrease in range of motion in the cervicothoracic region of the spine, or it can be used to help relieve pain of the patient. So it's a low amplitude, high velocity thrust, and that is the, like I said, the cervicothoracic manipulation.